Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on your journey to a 250. So currently we are in our reproductive system modules, and in this video we will be discussing in brief about reproductive system anatomy and ovulation and some of the hormonal changes. So, as I've talked in the previous videos, in the reproductive system, the lymphatic drainage and the arterial supply, these things are very important. And these are the things that are very frequently asked in the examination. So here we have a question with us. A 24-year-old primary gravid patient at 38 weeks gestation undergoes vaginal delivery of healthy twins after a prolonged labor course. Shortly after the placenta is delivered, profuse vaginal bleeding and the boggy uterus are noted on examination. So now the patient is having postpartum hemorrhage. Uterine massage and, uterotonic medications fail to stop the bleeding. The patient is taken to the operating room for laparotomy. Control of this patient's bleeding can be best achieved through bilateral ligation of which of the following arteries: common iliac, external iliac, internal pudendal, or ovarian. So this is the branches of internal iliac artery in a female. Here we have the common iliac artery, from where there is a branch of external iliac and internal iliac. So from the internal iliac, there are the major branches consisting of superior gluteal artery, inferior gluteal artery, um, uh, internal pudendal artery, uterine artery. Okay, and then we have the superior vesical arteries and pubic symphysis. So here we can see the most important part related to the question, that is the uterine artery. So also this is the venous drainage of the female pelvis. Here you can see there is the right internal iliac vein and there is the left internal iliac vein. Similarly, there is the right external iliac vein and there is the left external iliac vein. So the internal iliac, they all drain the uterus and the surrounding structures, and also the internal iliac artery, they supply the uterus and the surrounding structure. So you can see the internal iliac artery and internal iliac vein are the major blood supplies and venous drainage of the uterus and supporting structures respectively. So postpartum hemorrhage, an obstetric emergency, is the leading cause of maternal mortality. A common cause is uterine atony, as evidenced by boggy uterus. Surgery is indicated when medical management cannot control uterine bleeding. So whenever you think about postpartum hemorrhage, you think about four things, sorry. So they are the tone, trauma, tissues, and thrombin. So tone means that is uterine atony, which is the most common cause of postpartum hemorrhage. And another T is the trauma. So the trauma while delivery, if there is any sort of vaginal or cervical lacerations, that may bleed. So even if the uterus is firm and hard, it can bleed from the vagina. So that is the trauma. And after that, there is the tissue. If there's any region meets the placenta, then it hampers the uterine contraction, and there is the bleeding from that site. And again, after that, there is the thrombin. So if the patient is having any sort of bleeding disorders, then the patient will be having postpartum hemorrhage. So the main blood supply to the uterus is the uterine artery, which is a branch of the anterior division of the internal iliac artery. However, there are robust collaterals, example vaginal, to the uterus during pregnancy, such that in cases of severe PPS, ligation of the uterine artery may fail to control bleeding. Now, in these cases, bilateral ligation of the internal iliac artery, also known as the hypogastric artery, the main blood supply to the pelvis, is performed to decrease the flow rate and pulse pressure within all pelvic vessels, which can stop the uterine bleeding and avoid the hysterectomy. The structures supplied by the internal iliac arteries are typically unharmed by the procedure due to anastomosis with branches of the external iliac artery or eventual recanalization. Therefore, in women of childbearing age, fertility is preserved and complication rates, example buttock claudication, are low due to this anastomosis. So again, we have this one more question here. So this procedure will target which of the following lymph nodes? So we have a 64-year-old woman who comes to the office for evaluation of vulvar lesion. The patient has had a vulvar plaque for the past year that has slowly increased in size. She underwent menopause at age 52 and has a 30-year smoking history. Vital signs are normal. Physical examination shows a 1 centimeter non-friable white plaque on the right labia majora. The remainder of the physical examination is normal. A biopsy of the lesion is performed and shows squamous cell carcinoma. The sentinel lymph node biopsy is planned for cancer staging. Now, these procedures will target which of the following lymph nodes: common iliac, external iliac, immunofemoral, obturator, para-aortic, or presacral. So these are the primary lymph node drainage of the female reproductive system. So uterus is drained by external iliac group of lymph nodes. Cervix is drained by internal iliac group of lymph nodes. Vagina is the proximal third of vagina is drained by the internal iliac, and the distal third is by the inguinofemoral. The vulva is drained by inguinofemoral, and the ovaries are drained by para-aortic. So this patient has squamous cell carcinoma, the most common type of vulvar cancer. Patients with vulvar cancer typically present with either an ulcerative lesion or plaque on the labia. Risk factors include chronic human papillomavirus infection, prior vulvar lichen sclerosis, and tobacco use. Like most carcinomas, vulvar carcinoma can spread directly to the adjacent structures or from the primary site to regional lymph nodes. Therefore, ED cancer staging typically assesses for tumor spread in the first lymph nodes to drain the primary tumor site because they are most likely to have tumor involvement. The lymphatic drainage of the vulva is initially to the inguinofemoral nodes, which consist of a superficial inguinal and a deep femoral node. So as I've told you, blood supply and lymph node involvement is very commonly asked in the examination. Now, let's talk in some theories about the menstrual cycle physiology, okay? Because we're discussing the reproductive system anatomy and physiology. So here, this is the ovarian cycle. So there is a pulsatile GnRH secretion from the hypothalamus, and this GnRH acts on the anterior pituitary to release FSH and LH. This is same in both male and female. Now, FSH, when estrogen is low and GnRH is pulsing at lower frequency, it causes granulosa cells of developing follicle to use androgen precursors to make estrogen. The LS causes the theca cells of a developing follicle to produce androgens. Now, these androgens diffuse into adjacent granulosa cells and are aromatized to estrogen. Now, this is how estrogen is formed, right? So here we have the estrogen. This is how the estrogen is formed. Now, let's talk about the early follicular phase, and then there is the late follicular phase. So currently we are in the follicular phase. So the granulosa cells secrete activin, which is a hormone that increases the FSH production by pituitary. So please remember that this is a very important concept in this ovarian cycle. So please pay attention to this slide, and you have to rewatch this again and again. So there is increased FSH receptors on the granulosa cells and decreased theca cell androgen production. Now, this effect limits the conversion of estrogen, preventing estrogen from negatively feedback on anterior pituitary, which will reduce the FSH production. Now, this concept is very important. Now, this is how a negative feedback is protected or prevented, resulting in the high FSH level that stimulates the follicular growth. Now, you need to uh, expand or you need the follicles to grow and mature. So that's why you need unopposed action of hormones. Now, this is how it happens. So then there comes the late follicular phase. The granulosa cells of dominant follicle switch to secreting inhibin instead of activin. The inhibin, they decrease the FSH production by pituitary and helps the LH that increase the theca cell production of androgens. The increase in estrogen during this time increases the FSH receptors on the follicle. Again, there will be more maturation. It negatively feeds back on pituitary to reduce, not stop, FSH production. There is increased number of LH receptors on granulosa cells of the follicle, preparing for ovulation. The inhibin and activin are named for their effect on the anterior pituitary FSH production. Timely balance in steroid secretion between theca and granulosa cells is key to normal follicular growth. Disruption of this balance can lead to menstrual cycle disorders. Now here we can see there is the early follicular phase where there is typically low levels of estrogen, there is low levels of follicle stimulating hormone, okay, there is low levels of luteinizing hormones, and there is low levels of progesterone. Now, you can see in the late follicular phase, there is abruptly high increase in the estrogen here. Now, this high increase in the estrogen will lead to the follicular maturation, and the ovulation occurs due to the luteinizing hormone source that is called as LH source. The LH instantly picks up, and this leads to the release of the ovum. Okay, and then again it instantly comes down, and then the estrogen remains low at the time of ovulation, and then it again rises up to some level. Similarly, in the late luteal phase, for maintenance, so progesterone P, it maintains the pregnancy. So P for P, So that's why progesterone rises in the late luteal phase, because you need the uterus to have a favorable environment for implantation. That's what the progesterone does. Okay, progesterone has very important effect in the favorable in creating the favorable environment for the uterus. So there are some questions which have been asked about the which of the hormone prepares the uterus for implantation or pregnancy. The answer is always progesterone. Estrogen have not shown any big role in comparison to progesterone regarding the maintenance of pregnancy or maintenance or the functioning of the uterine endometrium for the maintenance of pregnancy. So always the progesterone is the one hormone that is involved in the maintenance of pregnancy. So again, here we have the ovarian cycle, the ovulation. How does ovulation actually occurs? So around day 14, the estrogen exerts sudden, very high positive feedback on the anterior pituitary, and it causes surge in the LH production and release. And this LH causes increased fluid production within the follicle and protrusion of follicle against the ovary wall. And then ultimately these forces release the oocyte into the uterine or fallopian tube. Now, this oocyte is actually released about 36 hours after the LH surge, even though it is commonly depicted as shown in the graph for clarity. So you can see that although LH surge, it does not typically happen just at the time of LH surge. So LH surge initiates a chain of reactions. These four things will happen, and these four things will take time, and then the ovum will be released within 36 hours. It is not like the LH is in the peak and suddenly the ovum has released. It is not the case practically, but for your sake of understanding, it is depicted like that in the graph. Next up, we have the luteal phase. Explain. So, besides ovulation, the day 14 surge in LH also stimulates a process called as luteinization, the maturation of the ruptured follicles, uh, granulosa cells into the corpus luteum. Corpus luteum begins to secrete a large amount of progesterone and a small amount of estrogen. The combination of high progesterone and estrogen negatively feedback on hypothalamus and anterior pituitary. There is decreased production of GnRH, FSH, and LH. Decreased FSH means there is no new follicles growing in the ovary in this phase, and decreased LH means there is less uh, stimulation for continued corpus luteum growth. So if implantation does occur, the HCG maintains the corpus luteum, so progesterone will be maintained. So if no implantation of embryo, the corpus luteum will degenerate, and after 14 days, allowing the GnRH, FSH, and LH to restart the ovarian cycle. Now, this is how the typical ovulation happens. So this is just from your basic sciences knowledge. There is the primordial follicle, there is this preantral follicle, this is this antron follicle, the mature follicle, and then it ruptures and, and releases the ovum. Now, this is just the histological picture of the corpus luteum. Now, again, corpus luteum is the glandular yellow structure developed from the ruptured graphene follicle after the release of the ovum, and it is also called as yellow body. Ovulation causes corpus hemorrhagicum, the corpus luteum, and if fertilization occurs, the corpus luteum of pregnancy, it is called as corpus luteum pregnancy, and if there is no fertilization, it degenerates and forms the corpus albicans. Again, this is the same thing that we have discussed earlier. And we have one last question before we leave. So which of the following hormonal changes is most directly responsible for triggering ovulation in this menstrual cycle? Decrease in progesterone, surge in the luteinizing hormone, rise in the follicle stimulating hormone, decline in estrogen, and increase in the prolactin levels. So again, the hormonal changes are crucial for regulating the ovarian and uterine events. Ovulation, the release of mature egg from the ovary, is a key process, and it is primarily triggered by a surge in the luteinizing hormone. Thank you for watching. Keep studying hard.